Welcome and namaskar to all viewers. Sorry for the slight delay. Today we have a very special guest and a very special topic for international faculty webinars, Professor Thomas Rimell. Sir, it is indeed a pleasure and an honor to have you, and we really thank you for sparing your time and teaching all the intensivists India and even globally. So, Professor Thomas Rimell is a professor in anesthesia and intensive care medicine at Edward Hillard Hospital, Lyon, France. He is chairman of the Department of Organ Harvest Coordination of the Hospital Civils de Lyon from 2014, sorry. And he is director of the Healthcare Simulation Center of the University Claude Bernard, Lyon, France. And his research interest is very much focused on the pathophysiology of injury-induced immunosuppression. And sir, I've seen some of his webinars. He's a very active speaker on dialysis especially. So I think it'll be a very useful session for all of us. You know, dialysis in various modalities, whether it's SLED, whether it's IHD, whether it's CRRT or other techniques when you use filters is a very big thing, and newer things are developing all the time. So it'll be very nice and I think educative for all of us to hear from Professor Rimell. Welcome, sir. Indeed, an honor to have you with us.
Thank you very much, Tapesh. Thank you very much for having me in your session today. And I will be talking about renal replacement therapy in the ICU. So during the next 45 minutes, I'm going to talk about different aspects of renal replacement therapy. So Tapesh, yes, we can share the slides. And so next slide. These are my conflicts of interest. I work with the different companies in the field of renal replacement therapy. Next slide. And this is the outline I'm going to follow. We're going to see all these aspects: the timing of renal replacement therapy, the dose of renal replacement therapy, the modality, which anticoagulation, and we're going to talk about citrate, regional citrate anticoagulation, of course. And we're going to finish with a few words about dialysis catheters. Next slide. Which timing? So the timing. So next slide. So we have two different situations, whether it is an urgent indication, whether it's not urgent. So when you have an urgent indication, there is a scientific consensus in the world. Everybody agrees. There is no debate. All the experts in the world agree when to start. When you have severe hyperkalemia, refractory to a medical treatment, when you have an uncontrolled severe metabolic acidosis, no problem, no discussion, we have to start. When you have uremic encephalopathy, when you have pulmonary edema refractory to diuretics, and when you have severe dysnatremia, then there's no problem. Actually, you have to start when you have a risk of death for your patient, okay? So there's no debate. Everybody agrees on the planet when we should start. So now when you have a non-urgent indication, when outside the context of an urgent indication, how does it work? Next slide. Yeah, so in this situation, there is no strong scientific consensus. And you can find two different approaches. You have the physicians who like to wait. Okay, let's wait a little bit, let's wait until we have urgent indication. And you have other physicians who are a little bit aggressive, who wants to start quite early. Two different type of intensivists. Okay, next slide. And I'm going to tell you that this is quite complex. This is quite complicated. Why? 3 reasons. The first reason is because there is no room for mistake. You know, if you are a doctor that you like to wait, okay, let's wait. not start today. Let's see tomorrow how, if there is still a deterioration of the renal function. If you are like this, in some patients, you are going to wait next day, and actually, after a few days, you will finally start. And this is not a good thing, because we know from the RRT trial that if you wait, and finally you start, the prognosis for the patient is not so good. On the other hand, if you are very aggressive, if you like to start very early, it's also not good, because if it is also demonstrated in the literature that if you provide renal replacement therapy to a patient who doesn't need renal replacement therapy, this is also deleterious. In other words, whatever your strategy is, there is a negative impact if you make a mistake, if you are wrong, actually. You understand? If you say, okay, no, I'm going to wait, and if you are making a mistake because finally 2 or 3 days later you have to start, that's not so good, because the prognosis is not good in this situation. And if you start in case the patient doesn't need, it's also not good, because if you provide renal replacement therapy to a patient who doesn't need, then it's exactly like if you provide antibiotics to a patient who doesn't have any sepsis. Of course, it's not good. So negative impact on patient's outcome if there is a mistake. Okay, next slide. That's exactly, this is an RRT trial, right? This is a French randomized controlled trial published a few years ago on 600 patients. It's a randomized controlled trial, 200 patients per group, early strategy versus delayed strategy. They did not find any difference in terms of survival. Okay. Interestingly, next slide. Interestingly, what they found that in the delayed strategy, if you wait, then a lot of 50% of the patients actually did not need renal replacement therapy. That's good, right? They wait, they decide, no, we don't give renal replacement therapy, and finally the patients recovered. So they were, in some situations, they were right to wait because the patient spontaneously recovered. But in other situations also, they waited, and finally they needed renal replacement therapy. And if you look at the next slide and the mortality rate, look at the mortality rate. If you provide in the RRT trial early renal replacement therapy, 48% of mortality. If you are in the delayed group and you don't, actually you are right to wait because the patient actually never received renal replacement therapy. Mortality rate 37%. Of course, right? It's good. They waited. The patient did not need replacement therapy. 37% of mortality. But if you make a mistake and you wait, and finally after a few days you need to provide replacement therapy, actually the mortality rate is 61%. That means that, okay, I'm gonna bet that maybe I can wait. If you are successful, the patient doesn't need, that's good for the patient, 37% mortality. If you make a mistake, finally the patient needs renal replacement therapy, then 61% mortality rate. And that's more than the early renal replacement therapy. So in other words, when you start renal replacement therapy outside the context of urgent indication, it's like you bet. It's like playing in the casino. You don't know, you don't exactly know. So you bet, okay, I'm gonna bet that I can wait. If you are right, good for the patient. If you are not right, then it's not good. So this is very complex. The timing of renal replacement therapy, the timing of initiation is quite complex outside the context of urgent indications. Next slide, please. Okay, next slide. So it is difficult to choose because, you know, if you have, if you decide to provide renal replacement therapy, you will have the consequences of anticoagulation, maybe the catheter complications, maybe it's also a little bit of workload for the nurses. Of course, it's a little bit of money. It costs a little bit of money to start renal replacement therapy, and also the patient will be in his bed, immobilization in the bed because of renal replacement therapy. But the positive things about renal replacement therapy, it's the control of electrolytes, metabolic homeostasis. The prevention of fluid overload is easy it's easier, I would say, easier in case of renal replacement therapy. And so you see that you have a balance of to start and to not start renal replacement therapy. So it's difficult to choose. And next slide, last but not least, no one can predict. This is what I was saying a little bit before. You know, when you are here, you have a rise of serum creatinine. At this time in 2025, nobody can tell you, next slide, nobody can tell you, nobody can predict in which directions the serum creatinine will go. That's why it's difficult. Can we get some help from the guidelines? Not really. Look, what they say, the KDIGO guidelines, they say you should just initiate renal replacement therapy when there is life-threatening organic conditions. So that's what we said for the urgent indications. But outside the urgent indication, the guidelines say that you should just start before the development of extreme metabolic derangements. So that doesn't really help. Next slide. So and so because of this, actually, what you do in India is very different than what they do in, I don't know, in China, in the United States, in Europe. There is a huge heterogeneity of practice in the world when it comes to the start of renal replacement therapy. This is demonstrated by many studies. This is also a work from Takar. He demonstrated that he proposed some situations online, and then he got what the doctors would do. Should they start or should they not start? And there were a lot of different answers. So a lot of different strategies in the world, but this is also true at the scale of a country. If we talk about India, in one city of India, it will be different than in another city of India. Even in the same city, or even in the same hospital in India, like let's say New Delhi, for example. In one hospital of New Delhi, you have a team of doctors, and they won't do if we take the same situation at night for doing a night shift. Some of the doctors of the team they will start, and some of the other doctors will not start. You see, there is a huge heterogeneity of practice in the world when it comes to renal replacement therapy initiation outside the context of emergency. Next slide. So when you look at the literature and all the recent major randomized controlled trials, you have the ALEN trial, the AKIKI trial, the IDEAL ICU trial, and the START AKI trial. And you know, the first one, the ALEN trial, so they are all randomized controlled trials. The first one was in favor of the early group. In the first study, they found that if they start early, then the prognosis was better. And the three other ones on the right, AKIKI, IDEAL, and START-AKI, they did not find any difference between the early group and the late group. Why? Why there is these differences between these four studies? Next slide. In the first trial, they had a lot of patients with fluid overload. because this is cardiac surgery patients. So in this study, in the ALN study, a lot of patients had fluid overload. There were a lot of fluid, a lot of retention of fluid accumulation in the body. So of course, in this situation, if you start a little bit earlier, it's good because we know that fluid overload is extremely deleterious for all the organs. Next slide. Yeah, look, this is the ALN trial patients. Okay, so 80%, almost 80% of the patients had a lot of fluid overload. They had pulmonary edema. So of course, if you start renal replacement therapy earlier here, it will be good for the patient. So actually, this is very interesting because that gives you a little bit of information that if your patient has a lot of fluid overload, a lot of, like the patient weight is like 10 kilos more than when he arrived in the ICU, then this is an indication that maybe in this situation, it can be interesting to start renal replacement therapy earlier than in your other patients. So I think fluid overload is a criteria to tell you that we need to start renal replacement therapy earlier in this situation. In the other situations, when there is no fluid overload, yes, probably now, based on the other trials, it's probably a good thing to wait a little bit and to start a little bit later than what we were doing a few years ago. Next slide. Because, again, fluid overload, I invite you to read this nice review on fluid overload. We know that it's very deleterious for all the organs. And you want, when you work in the ICU, you want to avoid as much as possible a fluid overload. Okay, next slide. So up to when you can wait, because it's good to say, okay, I'm going to wait because there is no hyperkalemia, because there is no pulmonary edema, so I'm going to wait. And then serum creatinine will rise, serum urea will rise. And so the same investigators who run the AKIKI trial, they run the AKIKI 2 trial like a couple of years ago. And they actually took the late group of the AKIKI and they decided that, okay, that will be our early group, the standard strategy, identical to the delayed strategy in AKIKI. And then they compare to another very much delayed, very, very delayed, up to 50 millimole per liter of urea. And then they compared the mortality in the two groups. So what did they find? Next slide. They found, the slide is not in the good, I don't know why. So there was an increased risk of mortality with the delayed strategy in this situation. Okay, so that means that you cannot wait too much. You can wait a little bit, but don't wait too much. If your urea reaches 50 millimole per liter, that means you have to wait as soon as possible. So to summarize the timing section of this presentation, you have a consensus on urgent indications. No problem, we have to start. There is no consensus when there is no urgent criteria. The literature today is more and more in favor of the waiting strategy, but not too long. Don't wait too long, because then you have an increased mortality if you wait too long, up to 50 millimole per liter of urea. And except in case you have fluid overload, I think it's good to start a little bit earlier. That's what I wanted to say about the timing of renal replacement therapy. Okay, so now let's move on to the second section about the dose, which dose of renal replacement therapy. I think it's very important to understand that the renal replacement therapy in the ICU, it's exactly like the antibiotics in the ICU. There is a dose of renal replacement therapy that you have to respect, that you have to give. So next slide. And this dose actually is well documented and it's well accepted by all the different experts in the world. There is no debate about the dose of renal replacement therapy. Okay? The KDIGO guidelines, the international recommendations, they say that you have to give a dose of 20 to 25 ml per kilo per hour of effluent if you provide CRRT in acute kidney injury. And that means that you have to prescribe a dose a little bit higher. You see, what I want to highlight here, my point here is to explain you that regarding the dose, there is a difference between the prescribed dose, what you prescribe in the computer, and what you give to the patient. Two different doses. When you prescribe an antibiotic, I don't know, tazocillin, 16 grams per day, the patient will receive 16 grams per day. Okay? But for renal replacement therapy, if you prescribe a dose, the patient will not receive the full dose. There will be a little bit of dose that will be not given to the patient. Why? Next slide. So that's before to answer this question, these are the two publications who gave the number from 2008 and 2009 in the New England Journal of Medicine, who gave the numbers of 20 to 25 ml per kilo per hour of dose of effluent. And you can go on the next slide. They were studying the different dose and they did not find a difference between a high dose and a low dose. And so they took this low dose of 20 to 25 ml per kilo per hour. And what I want to very much highlight now on the next slide is this table. You see, if I prescribe 35 on the right, I prescribe 35 ml per kilo per hour. 2 times per day or 3 times per day, the nurses, they are going to do the cleaning of the patient. And so at that moment, you will stop the delivery. You will not stop the blood pump of the renal replacement therapy, but you will stop the dialysate. You will stop there will still be the blood flow pump working, of course, to avoid coagulation, but then you will stop. This is the safety mode on the machines. So you lose a little bit of dose. Then the nurses, they have to change the bags. So you lose a little bit of dose. And then your patient, he has to go to surgery. He has to go to the operating room. He has to go to the CT scan. You lose a little bit of dose again. So that's why you understand that if I prescribe 35, then I'm going to get 25. Or in other words, if I want 25, because this is a recommendation from the KDIGO guidelines, I want 25 ml per kilo per hour of dose of renal replacement therapy. So to get this, I need to prescribe 35. If I prescribe 25, I will get less than 20 ml per kilo per hour. Not good. Under dialysis. Right? So that's why what I would like you to understand is to get this 25 ml per kilo per hour of dose of effluent, I need to prescribe more. I need to prescribe 35. You see, so when I'm talking about the dose, I make the difference between the administered dose, that's the title of the slide, the administered dose versus the prescribed dose. Next slide. So to summarize the dose section of this presentation, just make a difference. The most important message, the key message here is to understand you have the administered renal replacement therapy dose, 25 ml per kilo per hour, and the prescribed renal replacement therapy dose, 35 ml per kilo per hour. Okay, that was for the dose. Next slide. So now let's talk a little bit about the modality of renal replacement therapy. Next slide. So I would like first to tell you that it's very important to speak correctly when it comes to the abbreviations. In my team, a lot of people, they make mistakes. Sometimes they use the wrong abbreviations. So I think it's very important to understand CRRT stands for continuous renal replacement therapy. IHD stands for intermittent hemodialysis. CVVH, continuous veno-venous hemofiltration. CVVHD, continuous veno-venous hemodialysis. CVVHDF, continuous veno-venous hemodiafiltration. Sometimes even in my team, sometimes you have people saying, oh yeah, last night I put the patient under CVVH. But actually, in my unit, we do a lot of CVVHD. But it's because in their mind, sometimes they use the term CVH for CRRT, which is not good. Okay? So please pay a lot of attention to use the correct abbreviations when you speak about renal replacement therapy at the bedside. Next slide. So as you know, there are two different mechanisms to get some solutes removal. First, this is diffusion, the diffusion mechanism with this is hemodialysis. And as you know, you can give intermittent hemodialysis or continuous hemodialysis. And the other modality is convection. The other mechanism is convection. You have the removal of water plus molecules, and that's hemofiltration. And there is no intermittent hemofiltration, this continuous hemofiltration. And when you combine the two mechanisms, you do continuous hemodiafiltration. Okay, next slide. So there are actually two debates in the literature when it comes to the modality. The first debate is, should I give intermittent hemodialysis or should I give continuous renal replacement therapy? And then the second debate is, what mechanism should diffusion or convection when it comes to CRRT? And then you have CVVHD versus CVVH versus CVVHDF. But let's talk first intermittent hemodialysis versus CRRT. Next slide. So this is a huge debate for the last 25 years. And you have the protagonists of intermittent hemodialysis and you have the protagonist of CRRT. And sometimes when you go to an international conference, you will see a huge debate. It's very intense. They like to, okay, no, I disagree. I strongly disagree. No, I do intermittent hemodialysis. I'm doing CRRT. Actually, we do both. In France, 75% of the ICUs, we have the two modalities available in the ICU, intermittent hemodialysis and CRRT. And in my unit, I have the two modalities available, CRRT and intermittent hemodialysis. I don't know in India what you have, but there is this debate. Next slide. So actually the protagonist of intermittent hemodialysis are going to tell you, oh, you know, intermittent hemodialysis, it's much better than CRRT because with intermittent hemodialysis, you don't need anticoagulation. And intermittent hemodialysis is very easy to deploy at the bedside. And because of intermittent hemodialysis, thanks to intermittent hemodialysis, you can mobilize, you can achieve greater mobility to your patient because it's only a few hours. So after you can put your patient outside the bed. So that's good. And it's cheaper. And then you have the protagonist of CRRT that are going to tell you, yes, but with CRRT, you have a better hemodynamic stability. You have a better control of the volume status. You have a better control of electrolyte and acid-base status. You have a better control of temperature. It avoids the solute swings and cerebral edema, which is very good, especially when you have trauma brain injury, and a better uremic control. So you see there is this debate. Next slide. So actually, what the recommendation, the KDIGO guidelines, what do they say? They don't actually tell you anything. Look, use continuous and intermittent renal replacement therapy as complementary therapies in AKI patients. And that's exactly what we do in my center. We give CRRT when the patient is unstable in terms of hemodynamics. And when the patient gets better, we switch for intermittent hemodialysis. Okay? We suggest CRRT when in patients with hemodynamically unstable. We suggest CRRT when there is acute brain injury. Next slide. Then what about the literature? When it comes to mortality, no difference. There are a couple of meta-analyses available in the literature. No difference when it comes to CRRT versus intermittent hemodialysis. Next slide. Then there is another parameter which is interesting. It's the renal recovery. You know, you have your patient in the ICU. He received renal replacement therapy, but you don't know if this patient is going to recover. So in the literature, there are different publications reporting that if you give to your patient CRRT at the beginning, then the renal recovery is going to be better in your patient. There is this from Sweden, Swedish trial showing that the renal recovery is better. There is an association with a better renal recovery when CRRT was given first to the patient. Same result on the next slide in the Canadian study showing the same, showing that better renal recovery was associated with CRRT. Okay, next slide. Same result. This is a study we've done in France. This is one of my colleagues, Martin Bonacieux. We did the same work, and we looked at all the ICU patients in France. 1 million patients. Again, we found that there was an association between better renal recovery when CRRT was first initiated in the patient. Okay. Next slide. So, in other words, I think what I can suggest or recommend for the modality for the debate CRRT versus intermittent hemodialysis, if your patient at the very beginning is very unstable in terms of hemodynamics, when he has shock, I think it's good to provide CRRT because the renal recovery will be most likely better. Then we have this second situation. Okay, I'm going to give CRRT, but am I going to give CVVHD or CVVH or CVVHDF? Next slide. Actually, here there is very, very, very limited literature, very little literature in this situation. Next slide, yes. So we did a survey. This is an international survey, and India replied. We've done this. I was involved in this study. We sent to 74 countries. To many countries, and we got answers from 74 countries, almost 2,000 answers from physicians about what modality do you provide in your center. Next slide. So you see 1,700 colleagues who responded to our survey from 74 different countries on the 5 continents. How do you provide CRT or intermittent hemodialysis? What kind of modality do you use in your center? Next slide. What did they found? They found that when it comes to continuous modality, when it comes to CRRT, the most prescribed CRT modality is continuous veno-venous hemodiafiltration, CVV-HDF, in yellow on this cartoon, right? And in gray here, in gray is CVHD, and in orange is CVVH, and in blue is CRT not available in the ICU. Okay, so it means that the most prescribed continuous modality is CVV-HDF. When I do a survey, when I look everywhere in the world, the most prescribed is CVHDF. Okay, next slide. And after, when you provide CVVH, CVHDF, you can do a little bit of different ratios between convection and diffusion. You can do 50%, 50%. You can do 1/3 convection, 2/3 diffusion. You can do 2/3 convection, 1/3 diffusion. You can do different settings. Same for CVH. Okay, now here there is no more dialysis. In CVH, whether you provide pre-dilution, post-dilution, pre-post, 50-50, 1/3, 2/3, 2/3, 1/3, huge. The conclusion here is huge heterogeneity of practice, huge heterogeneity of settings. And again, what you do in India may be different what we do here in France, but I think no one can say what is best. North of India, south of India, probably it will be different. And no one can tell you, yeah, I'm doing a better thing than you. No, we don't know. We don't know how we should prescribe. We don't know the percentage of convection versus diffusion. We don't know the percentage of pre-dilution versus post-dilution. We have no data in the literature telling us the right answer. Next slide. So the guidelines cannot tell us anything. Next slide. Yeah. There is nothing on CVHD versus CVVH versus CVVHDF in the KDIGO guidelines. Nothing. You cannot find anything. There is no recommendation. There is no suggestion on this topic. Next slide. So the summary for the modality is this one, in my opinion. The use of CRRT as the initial modality in the ICU. The strategy to provide first when you have your patient in shock. You provide first CRRT when the patient is unstable, and then after you switch for intermittent hemodialysis. This is good because this is associated with better renal recovery after severe AKI. And this is potentially due to a better hemodynamic stability during CRRT. CVVHD, it's good. It's a good modality because you can work with a very low blood flow rate, right? With CVHD, you can work with a blood flow rate of 100 ml per minute. So I think this is good for citrate anticoagulation because if you work with a low blood flow rate, that means I'm not going to give a lot of citrate to my patient. If you use in your unit in India, if you use CVVH, that's okay, no problem. But what you have to calculate when you prescribe the CVVH station in the morning, you have to calculate the filtration fraction in order to not hemoconcentrate too much inside the membrane. And CVHDF, maybe it's a good compromise between the two, and that's why maybe this is the most prescribed modality in the world in 2025. Next slide. So now let's move on to the anticoagulation. And for anticoagulation, of course, I'm going to talk about citrate anticoagulation. Next slide. So citrate, so you have two types of anticoagulation for CRRT, heparin and citrate. I don't know if in India you have a lot of citrate anticoagulation today, but I think it's important to have, because with citrate, as you can see here on the slide, you can anticoagulate only the circuit as compared to heparin. And in heparin, you anticoagulate the circuit and the patient at the same time. Next slide. So do you want to give heparin in these patients? Like if there is a hemorrhagic stroke, or if your patient comes from the operating room, or if you have allergy to heparin? No, of course, no, you don't want. You want to give citrate in this situation, right? And that's, if you work in the surgical ICU, you will have a lot of patients who are at risk of bleeding. Next slide. So citrate, how does it work? Citrate binds the ionized calcium. The calcium here is the cofactor of all the different reactions of the coagulation cascade. So you bind the citrate, binds the ionized calcium, making calcium citrate complexes. Okay? So next slide. And that's how it works. You see, you have the citrate molecule here, and then you have the calcium, the divalent ion, right? And you have the positive charge and the negative charge here, your carboxylate radical. And so it binds, it can bind like this, and making the calcium citrate complexes. Interestingly here, when calcium binds citrate, you have one carboxylate radical here, free, with a negative charge. This ionic charge gives to these complexes a mild acidic effect. So when you have accumulation of calcium citrate complexes, that means that there will be a trend to metabolic acidosis. Okay? Next slide. This is important for what I will tell you a little bit later. Another thing which is very important with citrate is this. If you run heparin, if you do heparin in your unit, you give a little bit of heparin, that means you give a little bit of anticoagulation. If you give a lot of heparin, then I am anticoagulating my patient a lot. It's a linear association. With citrate, it doesn't work like this. With citrate, if I give a little bit of citrate and I decrease my ionized calcium to, I don't know, 0.9, 0.8, there is no effect. There is no bleeding time increased. There is no anticoagulation. There is an on-off effect with citrate anticoagulation, which means that if I want to give citrate to my patient, I have to do it 100%. I cannot be a little bit, I cannot say, okay, I'm going to give a little bit of citrate because I'm scared. I don't want to give too much citrate because my patient, I don't know if he will tolerate. So I'm going to give a little bit of citrate. No, if you do this, there will be no effect, no anticoagulation. Okay, so if you want to give citrate, you have to do it 100%. Next slide. So to give 100%, it means that you want to reach in the circuit an ionized calcium concentration of 0.3 millimole per liter. 0.3 millimole per liter of calcium in the circuit, it means that your citrate concentration is about 4 millimole per liter of blood. If I create calcium citrate complexes at the beginning of my circuit, because I give citrate at the beginning of my circuit, my calcium citrate complexes are going to be, some of them are going to be removed in the effluent, some of them are going to be metabolized in the patient. If I look at the next slide, you can see here at the beginning of the circuit, you have citrate given to your circuit, okay? It means that in the circuit, in the filter, in the membrane, there is 0.3 millimole per liter of ionized calcium. What is very important to understand, and a lot of physicians don't understand this, is that I have in my circuit 0.3 millimole per liter of calcium. Do I have calcium in my dialysate here? No, I don't have. I don't have calcium. So I have a gradient of concentration between the blood and the dialysate. It means that I'm going to lose some calcium. I'm going to lose some calcium in the effluent because there is a difference in the concentration. This is diffusion. Also, I have my calcium citrate complexes. Do I have calcium citrate complexes in my dialysate? No, I don't have. So again, I'm going to lose some calcium citrate complexes. And actually 50%, approximately 50% of the calcium citrate complexes are removed in the effluent. So I'm going to lose some calcium in the effluent on two forms, the ionized calcium and the calcium from the calcium citrate complexes. And what you have to understand, and this is what a lot of physicians do not understand, the calcium here at the end of the circuit is only here to replace the calcium that has been lost in the effluent. Okay? Calcium here is only to replace the calcium lost in the effluent. Next slide. Another thing which is very important. So you see, this is a picture when the citrate arrives here at the beginning of the circuit. The calcium arrives here at the end of the circuit. What I want to show here and to highlight here is that the dialysis catheter is not anticoagulated, right? Anticoagulation is only in the circuit, but the dialysis catheter here, not anticoagulated. So that means that if you want to give citrate anticoagulation to your patient, you need to masterize the dialysis catheter very well. You need to have good catheter because there will be no anticoagulation. That's why I want to talk about catheters at the end of this talk, because you cannot dissociate citrate anticoagulation to the management of the dialysis catheters because there is no anticoagulation of your catheter. Next slide. So citrate anticoagulation is one of the biggest improvements in the ICU during the last 30 years, for sure. Right? Citrate anticoagulation is very good. It's a very good anticoagulant, and it's more and more used in the world for sure. In 2025, it's impossible to run an ICU, to run CRRT sessions without knowing how to manage citrate anticoagulation. That's very important. If you do not use citrate in your unit, I strongly suggest that in the next few years you start a protocol of citrate anticoagulation in your ICU. Next slide. So because all the studies, the old studies, the recent studies, the big studies, the small studies, the European studies, the American studies, the Asian studies, the Indian studies, everywhere, the monocentric studies, the multicentric studies, everybody found the same thing. No debate. Citrate increases the filter lifespan, increases the duration of your circuit. Next slide. And this is true for monocentric, this is true for multicentric randomized controlled trial. Next slide. And because this, look, everything is explained here on this electronic microscopy picture. Heparin on the left, your capillary fiber is full of debris of platelets, debris of fibrin, and on the right, your capillary fiber, your renal replacement therapy membrane, remains very clean for up to 72 hours. Thank you. Next slide. And of course, with citrate, it's a regional anticoagulation, so you have less bleeding complications as compared to heparin. With heparin, you have more bleeding complications. Next slide. So that's why I think with citrate, you have less hemorrhagic complications, it's a longer filter lifespan, and you have less unwanted stops. So you don't have a problem with your circuit, so you can optimize your dialysis dose. Next slide. So what are the contraindications with citrate? Actually, they said liver insufficiency, shock, drug intoxications, okay, but without any precise definition. And next slide. So because you metabolize the citrate in the muscle, in the liver, in the kidney, in the mitochondria, and inside the Krebs cycle, which is actually the name of the Krebs cycle. It's also named the citrate cycle. So you need, for the metabolization of the calcium citrate complexes, you need to have a good functioning of the mitochondria of the Krebs cycle. Next slide. And the problem with citrate is you have a metabolic complication risk. With heparin, hemorrhagic complications. With citrate, metabolic complications. And all the metabolic complications are listed here. And if you want to get more information, I don't have time to go through all these metabolic complications, but you can read this publication that we wrote a few years ago. Next slide. It's published in Critical Care. Complications of regional citrate anticoagulation, accumulation, or citrate overload. I think you should get this publication to understand these two complications. Next slide. I will switch the slide because time flies, and I want to talk about the catheter. So yes, next slide, next slide, next slide. Next slide. So remember, you have these two complications, citrate overload and citrate accumulation. And in this publication that I was talking about, you can find what you have to do in case you face the two complications. Next slide. So how to predict citrate accumulation? I think the best, if I ask you what is the best predictor of citrate accumulation, I think the correct answer is lactate kinetics. When you are in the ICU and you don't know if you can use citrate anticoagulation because you are afraid of metabolic complication, look at your lactate level. If this is very high, then you are at risk of citrate accumulation. And if it's not very high and everything is under control, then you can provide citrate in a safe manner. Okay, so look at this publication of how to manage citrate anticoagulation with the complications in critical care. Next slide. Next slide. Next slide. And to summarize about anticoagulation, less hemorrhagic complication with citrate, longer filter lifespan, less unwanted stops, so administered dialysis dose which is optimized, and be aware that you have potential metabolic complication with citrate, and the lactate kinetics is the best to predict the accumulation of calcium citrate complexes. And I'm going to finish now with the dialysis catheter. Next slide. Dialysis catheter, this is the most frequent causes of alarm on the renal replacement therapy machines. You need to have a good catheter if you want to provide correct session of renal replacement therapy. Next slide. So if you have a good dialysis catheter, you can do really continuous CRRT session. Because if you tell me, yes, we run CRRT in my unit, we run CRRT. Okay, but if you have a lot of problems, a lot of clotting, a lot of interruption, this is not really continuous, right? Because you stop all the time. So I want to have no stops. I want to have a stable session for 72 hours. With a good catheter, this is possible. With not a good catheter, this is not possible. Next slide. So the Poiseuille law, you need to know the Poiseuille law, right? The Poiseuille law tells you that the QB is the blood flow allowed inside the catheter. The blood flow is directly proportional to the diameter of the catheter and indirectly and inversely proportional to the length of the catheter. If you have a long catheter, the blood flow allowed will be smaller than if you have a short catheter. Actually, this is the same like in the trauma resuscitation room. If you want to give a lot of blood products because there is a huge hemorrhagic shock in your trauma patient, you are going to give a lot of blood products on a short catheter because it will be faster than on a long central venous line, right? That's the Poiseuille law. Next slide. So your catheter tip, the tip of the catheter, the end of the catheter should be in a high blood flow rate location. You need to have a good blood flow around the tip of the catheter. And where you can get this? You can get this at the junction of the superior vena cava and the right atrium. Next slide. So that's why where do you place your dialysis catheter? The KDIGO guidelines recommend you to place in the right jugular, internal jugular vein. And for this, to reach this entrance of the right atrium, the junction of the superior vena cava and the right atrium, you need a 15 centimeter dialysis catheter. If this site is not available because you have, for example, the central venous line, you can place your catheter in the femoral vein. And if the femoral vein sites are not available, then you can go to the left internal jugular vein. Okay? So actually, you never go to the subclavian vein. And I hope you don't place your catheters in your subclavian vein. Okay? By order of preference, right internal jugular vein, femoral vein, left internal jugular vein. Next slide. So this is based on studies reporting that you have catheter dysfunction in the left jugular vein side as compared to the right. So it's better to place on the right jugular side than to the left. Next slide. The diameter, it depends on your modality. If you run intermittent hemodialysis, you need a quite big catheter because your blood flow will be high. If you run CVVHD with a low blood flow rate, you don't need that much big catheter because you have a low blood flow rate. It depends on your modality. Next slide. What is catheter recirculation? I think this is very important to understand. Here you have your catheter inside. Here the blue arrows show that there is a high blood flow rate. The catheter recirculation is when you have here the blood enters the catheter here. Then there is the cleaning of the blood, and then the blood goes back to the circulation on the distal hole. When you have a little bit of blood, clean blood, going back again to the circulation, this is recirculation. You don't want recirculation Recirculation is not necessary. Recirculation is like you are going to clean a blood which is already clean. It's like you clean twice your clothes, right? You don't do this in your home. You don't clean your clothes twice, right? It's like the same for the blood. You don't want to clean the blood twice. So you don't want this recirculation. To avoid this recirculation, you need to be in a high blood flow rate location because the blood here will be pushed away when it goes out because of the high blood flow rate. You have a distance of 2 to 3 centimeters here, avoiding the recirculation, and you never switch the line, right? If you switch the lines, then of course your recirculation will be increased very much. So do not switch the lines. Next slide. So that's how to limit recirculation, the distance of 2 to 3 centimeters. You need to be in a high blood flow rate location, and you do not reverse the outflow and the inflow lines. Next slide. So you want in your catheter a laminar flux. You do not want a turbulent flux because turbulent flux means coagulation, thrombosis. So you want to avoid the turbulent flux. Next slide. So to avoid the turbulent flux, you want to avoid these angles here. You don't want angles because that means turbulent flux. So the best type of catheter is this one with this no angles here. The cycle C catheter is the best catheter. Next slide. The 3-lumen catheter, next slide. It could be interesting, but not necessarily. You can use, just pay attention that if you have 3 lumen, of course, the diameter of the lumen, internal lumen, will not be that important as compared to a 2-lumen catheter. Next slide. The tip of the catheter should be this one. Do not use these catheters here. The pointed catheters are not very good because these lateral holes will be responsible for a lot of turbulent flux, so a lot of thrombosis. This one, the shotgun catheter, is the best catheter. Next slide. So to summarize for the catheter, optimal diameter from 12 to 16 French, cycle C catheter, shotgun tip catheter, right jugular vein or femoral vein. Avoid the left jugular as much as possible. Do not place your catheter in the subclavian site. No line reversal. Of course, you have to place the catheter with the use of ultrasound guidance. You have to use biocompatible material to check the correct position with chest radiography and remove it as soon as possible. Next slide. So to summarize the entire talk, if you want to provide to a patient a continuous, safe, and efficient CRT session, all the aspects of the CRT prescription should be masterized. The dose, the timing, the modality, the anticoagulation, the catheter should be masterized. Of course, we didn't have enough time to talk about the renal replacement therapy weaning, the renal replacement therapy termination, the renal replacement therapy membrane, but this also needs you to pay attention to these aspects. Thank you very much for your attention, and I'm ready to answer your question if you have any question.
Thank you, sir. Thank you very much for a wonderful talk. Very nice and I think very informative, and I'm sure all our intensivists and students will find it very useful when we put it up there, and I found it very useful because there's an audience, very big audience. So fellows and guys, if you want to put up any questions, sir is happy to answer them. And sir, meanwhile, while we wait,
it's not a good idea to provide heparin because there will be a risk of bleeding, a high bleeding risk if there is a coagulopathy. And so I think in case of coagulopathy, citrate anticoagulation is a very good indication because again, you will anticoagulate only the circuit and there will be no anticoagulation going to the patient. And so I think it's a good idea to provide citrate anticoagulation when there is coagulopathy.
thank you, sir.
In my unit, there is no, contraindication to citrate because we have a lot of experience with citrate. So now we start citrate to all the patients. Even when there is a shock, even when there is a intoxication, even when there is a lactate level very high, we provide citrate. We test citrate if we can do it or not. We start with citrate. And if there is accumulation, then we stop. But we start to all the patients because I think it's a very, very good anticoagulation. Do you use a lot of citrate in India? Do you have a lot of citrate?
Yes,
Now,
yes. We use citrate definitely.
very good, very good.
Okay, so then moving on to extracorporeal blood purification. I know that's a little, maybe a little out of context, but I think it's very important to hear from you. You know, we have been using, there have been a lot of papers on use in sepsis especially, but the
Yes.
trials and the evidence is very heterogeneous because of the nature of the trials. But has been a recent paper, I think, by Dr. Romko and Dr. Vincent, sir, and they have said that, yes, if you choose the patient correctly, filtration has a extracorporeal blood purification has a role in sepsis. So would you like to comment, sir, whether it's helpful, what kind of patients, what kind of filter?
Yeah. So yeah, extracorporeal blood purification for sepsis. This is a very controversial topic in the ICU. You have a lot of in different countries, you have different possibilities, and you have different devices. You can use hemoadsorption filters, membranes, like polymyxin B hemoadsorption, like cytosorbs, like Jaffron technology. You can have high volume hemofiltration. You can have different membranes with auxiliaries, with PMMA, with Fresenius high cutoff membranes. All of these are different modalities for blood purification. The evidence in the literature is very low, but we need to study this field. We need to get more studies with blood purification because septic shock is the primary cause of death in the ICU. We have a lot of people dying because of septic shock. And even if you do very well antibiotics, the organ dysfunction management, the control of the source of the infection, even the mortality rate would be 50%, 40 to 50%. So we need to find some adjuvant treatments. And these blood purification devices, they are very promising. Some studies are positive, some studies are negative, but I think they deserve that we study this very much. And we could talk, I could talk about blood purification for hours, and maybe another time we can do a talk on blood purification for sepsis if you want. But I think at least we should study them. Okay? So yes, we should study hemoadsorption, auxiliaries, Fresenius membranes, all these devices are, I think, potentially very interesting.
Thank you, sir. Thank you for answering. So another point that can be discussed, sir, for everybody, you talk about fluid removal, and that is an early indication, that evidence also you showed. So we all understand that, sir, but there are situations where fluid removal can be difficult, such as if the intravascular volume is depleted, when you start him on dialysis, there can be hypotension. So what is the best strategy in these patients?
So this is a very good question, Tapesh, because the first thing I want to say about fluid removal is that when you take all the parameters of the renal replacement therapy prescription, the net ultrafiltration, which is actually the fluid removal you're going to get from your machine, is the most difficult parameter to prescribe. At the beginning, you don't know how really the patient will react. The feedback of the patient at the beginning, if you place 50 ml of water removal per hour, you don't know if the tolerance will be good or not. It's very difficult to prescribe. What I want to suggest, what I want to recommend is when you prescribe net ultrafiltration of 50 or 100 ml per hour, you have to see and you have to go back to your machine and see if the tolerance is okay. That's the first thing I want to say. So go back to your machine in the afternoon. You make the prescription in the morning. In the afternoon, you go and see on your machine if you have a good tolerance to your fluid removal. If this is good, you can increase maybe. You can go from 100 ml per hour to 150 ml per hour. If the patient not good tolerance, then you can decrease. Okay? It's a dynamic process. Just go back in your unit to see. Second thing, your albumin level. Of course, your albumin level should be a little bit above, it should be above 20 ml, 20 gram per liter. Sometimes I arrive in the ICU I arrive sometime on the night shift in the ICU and I see a albumin level very, very low. Then of course it's not possible to remove the fluid from the, because you will have a lot of problems. It's impossible to get the fluid. You need to have a certain amount of oncotic pressure to tolerate the fluid removal. So fluid removal with the renal replacement therapy is a very complex question, a very difficult parameter. So I have two advices. First, in the afternoon, go back 24 hours all the time. You go back to see if the tolerance is okay, and then you adapt. At the beginning, there is a little bit of, I don't know, let's start with 50, let's start with 100, and then you adapt. And the second thing I want to say, be careful with your albumin level.
Yeah, thank you, sir. Thank you very much. We understand that it's very difficult. Now, just a couple of points more for discussion, sir. And this is again a very dicey situation. Antibiotic dosing in AKI and CRT, sir. What dosing guidelines for antibiotics exist? Evidence-based is for CKD patients, and these have been extrapolated to AKI and to perhaps RRT. However, this is not correct. As you know, there is no clear dosing in RRT patients. So what kind of advice can you give us for dosing of antibiotics on RRT? I know we have therapeutic drug monitoring coming in, but that is not possible and will take time because it's expensive and everything, and definitely third world countries and LMIC countries are not going to get therapeutic drug monitoring so soon.
Yeah, Tapesh, I think this is a good point also. The only advice I can give with therapeutic drug monitoring is to do it as much as possible. And it's easy to monitor, for example, aminoglycosides, amikacin, gentamicin, then it's easy. Vancomycin also, usually, it's easy in many centers. For beta-lactamines, it's more difficult. And even in France, we have only a few labs which are able to give us the correct concentration of antibiotics. But my recommendation is to do as much as possible therapeutic drug monitoring. Yes, it's a little bit costly, but I think to adapt your treatment is very important. And I'm not obsessed by the cost. I think if you provide, if you did not, if you don't give enough antibiotics because you don't do therapeutic drug monitoring because it's expensive, then you will not cure your pneumonia, and so your patient is going to stay in the ICU for 7 more days or 10 more days, and that would be a big problem. It would be, at the end of the day, it would be much more expensive. So I think it's a little bit of investment with drug therapeutic monitoring. Again, if it's possible in your center, it's at the end of the day you will save money. It's like you put one euro or $1 here, and then you get back 10 euros because it's a little bit of investment, but it can save ICU days. It can decrease your ICU length of stay. So I am very much in favor of controlling these aspects of controlling the concentration of antibiotics.
Thank you, sir. Thank you very much. Just a last point, sir.
Yeah.
Could you just touch upon, renal replacement therapy and neurocritically ill patients, traumatic brain injury and other neurocritically ill? Because here I think definitely there are certain differences. So if you can just touch upon that, sir.
Yeah, no, you are talking about trauma brain injury,
Traumatic brain injury or other kinds of neurocritically ill where there is raised ICD and blood-brain barrier is breached. So here, there are other aspects like fluctuations in osmolarity.
Yeah. So the only thing we should say here is like you should avoid as much as possible to provide in these patients intermittent hemodialysis. You should provide CRRT in these patients because the solute swings are too important with intermittent hemodialysis. And then you can give a lot of damage, secondary damage to your brain with intermittent hemodialysis. So yes, brain injury, if you have a brain injury, only CRRT. Please don't provide intermittent hemodialysis. Too dangerous for the brain.
So just to adding to that, sir, sometimes there is a rise in PCO2 also, which leads to cerebral vasodilatation when you do dialysis.
I'm sorry, I didn't understand.
Rise in carbon dioxide levels, which leads to vasodilatation, because you add SCO3 and there is a diffusion and it leads to a CO2 rise.
Yeah.
Do you see that in your dialysis, or?
You mean the level of to adapt the sodium?
Yeah, the bicarbonate is added, so there's acidosis. So the bicarbonate and the hydrogen ions react, and the rise of CO2 in the blood sometimes. We have seen that sometimes.
You're talking so in case of citrate anticoagulation, right?
Not citrate, sir. Just standard dialysis. You are adding bicarbonate and there's acidosis, so there's a liberation of CO2, and sometimes PCO2 levels can rise, and that can lead to vasodilatation. Does that?
Okay.
Do you see that?
No. Yeah, I think you're right, Tapesh. It's very important to control the CO2 level in your patient on your blood gas analysis. Remember that the best way to control also the CO2 is with your respiratory machine, right? If you have an increase of your CO2 in your blood gas analysis, you can increase ventilation to decrease. So we do not add bicarbonates or in the diet. We don't use these kind of strategies to stabilize the hemodynamics. On the other hand, what we do is we have.
Right, sir. So, Professor Rimel, sir, really thank you from my side, from our young Indian intensivist side, and all the audience. It has been a wonderful session, wonderful audience, and I shall be putting this up on our YouTube channel, so all the global community can go through this, especially our younger fellows, and I'm sure the senior fellows will also learn much from this. I have also learned, sir. Thank you very much, sir. Really, thank you very much.
Thank you very much for having me.